Now let's talk some more about osteosarcoma, including the basics and the pathology, clinical manifestations, and we might even get into diagnosis. So let's start. So regarding osteosarcoma, the adolescent growth spurt is the period of highest incidence for osteosarcoma, suggesting that rapid bone growth predisposes to malignant transformation because of a chance genetic error occurring during this period of repeated cell divisions. As noted above, patients with hereditary retinoblastoma and Li-Fraumeni syndrome are predisposed to develop osteosarcomas. Other association with osteosarcomas is the rare Rothman-Thompson syndrome, characterized by short stature, skin telangiectasis, and small hands and feet, and hypoplastic or absent thumbs. In old individuals of older than 50 years of age, Paget's disease has been associated with osteosarcomas because of prolonged duration of accelerated bone remodeling. Now regarding the pathology. Osteosarcomas most commonly occur in the distal femur, proximal tibia, and proximal humerus. The pathologic hallmark of osteosarcomas is the presence of highly malignant, pleomorphic, spindle-shaped cells with bizarre mitoses and the formation of osteoid. Although there are 4 different histologic types of osteosarcomas, there are no differences in outcome to treatment of the 4 subtypes. Now, a little about the clinical manifestations. Osteosarcomas typically present with pain and swelling over the area of the affected bone. All too often these symptoms are attributed to a sports injury or sprain. However, if after several weeks of conservative therapy there is no improvement, a more thorough investigation to rule out a more ominous cause of the symptoms must be pursued. Diagnosis. One of the clues to a bone tumor is pain that causes awakening from sleep. Not uncommonly, a mass is palpable. An X-ray of the affected bone is mandatory. The radiograph will disclose a lytic lesion, often with a spiculated periosteal reaction, the so-called sunburst pattern. In addition, there is a cuff of periosteal new bone formation called Codman's triangle. Once the radiograph suggests an osteosarcoma or another bone tumor, the patient should be referred to a center with expertise in managing such tumors. Because osteosarcomas metastasize to the lungs, a chest CT and radionuclide bone scan is necessary. The differential diagnosis of a lytic bone lesion includes Ewing sarcomas, lymphomas, bone metastases, and histiocytoses. While osteosarcomas can usually affect the metaphyses, Ewing sarcoma usually involve the diaphyses, but this is not a hard and fast rule. A core, needle, or open biopsy by the surgeon who will perform the definitive surgery is highly recommended with a pathologic diagnosis. The surgical and chemotherapeutic regimen can be mapped out.